Good evening. My name is Dr. Nina Ahmad, and I will be your moderator for this session on COVID-19 by the American Academy of Family Physicians. We will have a brief status update and a guest speaker. You can ask our speakers questions before and after each session through the COVID-19 Rapid Response Member Exchange message board. You can also ask questions through the chat feature. Speakers will try their best to answer as many questions as they can, and these sessions will be recorded live so you can always refer back to them. This will be our last session of the series as we are paring down for the COVID-19 CME portion of the response. These sessions are being put together based on your feedback, so if you need any information on the ground as the COVID-19 crisis continues, feel free to respond on the message board, and it is being monitored, so your feedback is helpful on how we proceed forward. This session is approved for 1 AAFP prescribed credits. It's an enduring credit, so you can always refer back to it. It's also approved for 2 T2P credits or translation to practice. And the speakers today have nothing to disclose. Here are today's learning objectives. And first we'll go over a current situation summary with a little bit of background, and then we'll have our guest speaker, Dr. Laura Jordan, join us. We'll have question and answer, and then T2P reflection. So here's a graph that we've talked about previously, and it looks at the total confirmed COVID-19 cases, and since the 100th confirmed case. This is as of today, July 8th, 2020, and you can see in red the United States, in blue the United Kingdom, and in green China. Here you can see the distribution of cases and deaths by jurisdiction. You can see the states as of today as well, and the total number of cases at over 2.9 million, and total deaths at 131,065. So this information here, it's from Johns Hopkins University. You can see the link at the bottom. It's really helpful. It shows the epi curve for all the states, and it's interactive, and it shows the daily confirmed new cases on a 3-day moving average. We had talked about looking at 3-day or 7-day moving averages to help eliminate as much as possible the variability from day to day. And so this goes on a 3-day moving average. So this is as of today. And when you see the greener the background, that means the bigger downward trend of new cases. And the redder the background means it's the bigger upward trend of new cases. The dot shows the current day, the most recent day. So it's an interactive chart, so you can click on whichever square. And here I clicked on Louisiana, which was the highest reddest background, and you can see a closer look at the epi curve. The dotted line shows where you have the highest number of cases on the 3-day moving average, and then you can see in the rectangle, the red color, which shows that it's on an upward trend over the most recent 2 weeks. And for the 2 articles we're going to go over today, we're going to talk about a little bit of background of what's going on with coronavirus and some information that's been in the news, and then how it relates to vaccines and where we're going. So the first article has been talked about in the news quite a bit, and this one is the article from Cell, and it was produced on June 26th. And published, and it was entitled Tracking Changes in SARS-CoV-2 Spike, Evidence that D614G Increases Infectivity of the COVID-19 Virus. So I just want to preface that some scientists agree with the information from the article, and some scientists think we don't completely agree, but a lot of people think that we need additional information and as we move forward to try to understand this a little bit more. So the article points out that coronaviruses have genetic proofreading mechanisms, which we know, which results in the diversity being very low. However, natural selection can act upon rare but favorable mutations, and of this we know antigenic drift is a potential. And one example that we know about regarding antigenic drift is the gradual accumulation of mutations during influenza virus during the flu season. And we know that drives the need for new vaccines every few seasons. The longer a virus is in the environment, for example, during this pandemic, it may enable accumulation of relevant mutations more and more. So we do know that common cold coronaviruses and SARS-CoV-1, which is compared to SARS-CoV-2 quite a bit, do show antigenic drift. The authors point out that understanding the evolutionary transitions and the risk of this now is very relevant to knowing the fitness of the antigenic profile for the virus. And it's also very important to ensure the effectiveness of treatment options that we may have available. So for vaccines and immunotherapeutic interventions, at the time of the publication of this article, they had pointed out that there were over 90 vaccines and 50 antibody approaches being explored, such as COVID-19 convalescent plasma. They mostly target the spike protein, and we had talked about this previously, how that mediates host cell binding and entry, and it's also a major target of neutralizing antibodies. Alterations in the Wuhan reference sequence proteins could alter the viral phenotype and/or efficacy of immune-based interventions. And they stressed in the paper that they were evaluating spike evolution and other organizations as well, and how important that was to do this to enable the testing of these mutations. Other reasons they pointed out that this was very important was that most immunogens and testing reagents during this pandemic are based on the spike protein sequence of the Wuhan reference sequence. And also, first generation antibody therapeutics were evaluated using the same reference sequence proteins. So what you can see this graphic here that was in the paper, and you can see how in early April, a SARS-CoV-2 variant carrying the spike protein amino acid change D614G has become the most prevalent form in the global pandemic. And in the second graphic, you can see G614 variant is associated with greater infectivity and lower CT values, which is suggestive of higher viral loads. So I want to remind everyone, CT values we talked about before is cyclic threshold, and which is inversely proportional to the amount of nucleic acid that may be present. So if you have a lower cycling time, like they found on G614, higher nucleic acid would be present, which is suggestive of higher viral loads. So is it more infectious? The information that the authors from the paper gave to try to talk about this was that global tracking data has shown G614 variant spike has spread faster than D614. They also talked about in vitro studies showing higher infectivity, and also the lower patient CT values that we just talked about. They did note that it was not significantly associated with hospitalization status, but they did have higher fatality rates, which they attributed to how people, what resources people have in different countries, and the difficulties in access of care, which might contribute to higher fatality rates. They acknowledge that potentially what would make G614 variant look more infectious potentially is related to an epidemiologic effect, and sampling bias could also account for this. They also noted other limitations, such as lab experiments not being necessarily natural, and transmissibility is not synonymous with infectiousness. But the authors do postulate that it could be a combination of evolutionary, where there's mutations, and epidemiologic, for example, that a G614 variant spike may have gotten into populations where they traveled more and spread more readily to other locations. So, in summary, SARS-CoV-2 variant carrying the spike protein amino acid change D614G has become the most prevalent form. The change occurred even in the local epidemics where the original D614 form was well established. This pattern was highly statistically significant. And like we had talked about, an infected individual's G614 is associated with the lower cycle thresholds, which in turn is reflective of higher levels of viral nucleic acid, like we talked about in upper respiratory tracts. But they did not see an increase in disease severity. So the next paper was written in May and had a number of authors. It was in Science Magazine, and it was a policy forum. And one of the authors was Dr. Fauci, and it was a very good summary of some of the steps that we need to take to get to the point where we have a vaccine available. So if you want to refer to it, the link is at the bottom. So they go into talking about what we need, and obviously we need to manufacture and distribute enough safe and effective vaccine to immunize a large number of people to protect the global community. They do recommend or comment on the need for more than one effective vaccine approach and the combination of academia, government, and industry working together. So they talk about one particular public-private partnership, which would incorporate these organizations working together. And this was the NIH model. So not trying to push one particular public-private partnership, but it's helpful to hear what one partnership is doing. So their version is Accelerating COVID-19 Therapeutic Interventions and Vaccines, also known as ACTIVE. It's a collaborative platform for conducting harmonized, randomized, controlled vaccine efficacy trials to accelerate licensure and distribution of multiple vaccine platforms and vaccines. So for the protective immune response, SARS-CoV-1 and SARS-CoV-2 patients we know have documented high levels of immune responses after infection, particularly to the spike protein. In vivo data on type or level of immunity required to protect from reinfection duration of protection is unknown. We need more time. It seems like the pandemic has been going on for quite a bit of time, but it's actually been quite short considering what's been going on. And protection against experimental infections in animal models of SARS-CoV-1 have been found in immunization with recombinant subunit proteins and viral and nucleic acid vectored vaccines and passive transfer of neutralizing antibodies to the spike protein. So this actually is some positive information that has been identified in the past and is promising. So for vaccine safety, they talk about how that is the primary goal. A high degree of safety is the primary goal of any widely used vaccine. There is a theoretical risk that vaccination could make a subsequent infection of SARS-CoV-2 more severe. It was seen in feline coronaviruses in vaccine challenge animals models of SARS-CoV-1. This was in the preclinical data, which was suggesting poorly protective antibodies that produced immune complex deposition in combination with T helper cell 2 biased immune responses, resulting in a syndrome of vaccine-associated enhanced respiratory disease. So at the time of this paper, the potential mechanism and ways to minimize this had been recently reviewed, and animal models of SARS-CoV-2 infection in development to understand immune responses associated with protection. And so this is the reason why we do preclinical trials. And then for clinical and immunological endpoints, they mentioned that the commonly mentioned endpoints for a lot of these trials is protection from infection, which they're defining by seroconversion. We talked about previously in our talks. And then also, obviously, prevention of clinically symptomatic disease, especially severe disease. Evaluating this type of endpoint where you have a reduction of disease actually requires a large number of enrollees into a trial. They point that out. And also, they point out the need for similar serologic assays for testing in the trials. We've talked about, and we know from experience throughout this outbreak, that the serologic assays have been different, and to compare them in clinical trials, having them as similar as possible is helpful so that there could be appropriate comparison. The efficacy of the trials need to be evaluated for benefit and harm, so a more prolonged follow-up of the initial vaccine cohort would need to be undertaken. And the durability, which we know about from other vaccines, so it's not a surprise, that the durability of clinical and serologic endpoints will need to be explored. Waning immunity is common with human coronavirus infections, so it is possible and not unexpected. So here is the active model, the NIH model for SARS-CoV-2 vaccine development. That's currently going on. You can see the different candidate COVID-19 vaccines and platforms. So they have a proposed government-supported infrastructure where there's harmonized efficacy trials, collaboration between clinical trial networks, collaboration with the labs, a data and safety monitoring board, and then between trial statistical groups for correlates of protection. So where we are, in summary, there has been some genetic drift during the evolution of the SARS-CoV-2 epidemic, but major alterations in the spike protein were not extensive, especially in regions thought to be important for neutralization. And everyone has cautious optimism that the vaccines designed now will be effective against circulating strains 6 to 12 months in the future. With that, I do want to point out before we introduce our guest speaker that there recently has been a lot of information going to WHO that about how COVID-19 is transmitted over airborne versus droplet, and additional information. So they will be releasing some information according to WHO shortly, within a few days. And to look out for that. So now I'll introduce Dr. Laura Jordan, and she is Chief of Family Medicine at United Family Shenqing Hospital, Shanghai. She's former Infection Control Chair, and she has been practicing with United Family Hospital since 2016. She's a native of the Pacific Northwest and an Oregon Health and Science University grad, and we're happy to have her again. She was our first speaker, and she's here again to end the series. Thank you.
All right. Thank you so much, Nina. It's really great to be back with you and all of our colleagues at AAFP. Good morning, Shanghai. Good morning, Wuhan. Good evening, US. And I'm really pleased to be back here with you. So this is where I ended last time, and this is where we're starting. We will get through this. This is my team, and as Dr. Ahmad noted, I have some background in infection control as well. This was us in January, and you're right, Nina, it doesn't seem like that long ago, yet it seems like ages ago. March, I came back to the US to visit. This was the status of the cases at that time. This is when I spoke last time. The proportion of cases in China and US, and this is now. So where we are now, we are living in a post-peak time here in Shanghai, which is basically normal life with masks. These are my colleagues here at our blood donation drive. So our status right now in China, there are 403 active cases and another 114 asymptomatic cases under observation. We are not experiencing community spread at this moment, but we expect we'll continue to see new outbreaks that are brought under control, and that likely will be the future for us all once the peak goes down, is continued surveillance. And so our new normal, and I'll talk about these areas, sporadic outbreaks with hopefully rapid control through testing, contact tracing, and much more localized lockdown. A life with open schools with social distancing. Here, masks are required on public transport in many locations and are the social norm, which I'll talk about a little more at the end. We are able to travel pretty much freely within China, but still no crossing across the border. And we keep all of the strict infection control precautions that I discussed earlier. So a brief look at the latest outbreak here in Beijing in mid-June, June 11th through July 3rd, essentially. By the 6th, this outbreak was under control. This is a market that brings in 80% of the fresh food into Beijing. And cases were identified when a febrile patient was tested for coronavirus. Then through contact tracing, it was traced to this location and rapidly brought under control. After hearing your run through yesterday, Nina, then I looked at the data on the D614 variant, and that outbreak in Beijing was in fact the new variant thought to be more infectious. With this in mind, the highest risk infected people and the highest risk people for infection were actually then kept under quarantine for 28 days. So that's a significant change. So travel restrictions were instituted and now have been lifted again. Testing, 10 million tests were done in Beijing in that 3-week period. The mandated maximum price is about $17 US. The testing started in concentric circles of priority, starting with the market, positive cases. Additional priorities were people who have a lot of contact with the public and people who can't social distance, such as the delivery drivers and hair and beauty salon staff. Out of 100,000 Kuaitis or delivery drivers, 1 tested positive. Schools did restart. I am happy to share extensive data on what was done to keep schools open safely. I believe you have my email. You can also find my email through my hospital website for more information. But children have to be afebrile. There's hand hygiene at entrance. There's social distancing. Mask use at all times except with meals. And for meals, then students are sitting on one side of the table. There's nobody on the other side, and students are distanced with meals. And there's a lot of thought that goes into isolating a sick child, strict return to school guidelines, and making sure the virus isn't reintroduced in the school population. So in the US, I know that's a big debate right now. Will schools reopen? I don't know. But if you are able to be a resource for schools, think about how would you handle a child who presents with a febrile illness at school? What about choir? We know that choir is a special risk for transmission. Band, having all that saliva going through those instruments, sports. So there's some special areas to think about, and I'm happy to share more information. Mask use, even the youngest can wear masks. My colleague, her young son, who tolerates wearing a mask, it is the social norm here. And then when you're eating and drinking, you can just pop that on your arm if it's one with the elastic loops there. Schools opened after transmission, community transmission was eliminated. So what I can't tell you is whether these measures are going to prevent students from bringing this home. when there is ongoing community transmission. We continue to practice really intensified infection control, and now we are also doing testing. We have not, in our hospital, actually treated coronavirus. There are very few cases total identified, about 700, less than 800 in the entire pandemic. Our hospital is not a dedicated site for treating febrile illnesses, so I actually don't have experience with treating coronavirus, but we continue to be extremely vigilant about monitoring for potential cases and transferring for treatment when needed. So we continue door triage. Even though we are beyond community transmission, this is how we look. Areas of risk are updated. So a patient presenting to us with a history of travel through Beijing the last 3 weeks, and we were especially on note. We are not receiving international traffic now, but we expect that we will always be monitoring areas of increased transmission and patients who come to us where they have traveled from. We continue to see all of our patients with respiratory symptoms in our negative pressure suite, patients with suspected infectious diseases. This is a separate entrance, remote checkout. These patients are entirely separate from our well patient population. When we last spoke, dental care, ophthalmology, ENT, gastroenterology were not operating, but we are now able to reopen. So we are basically back to full operation since April, now that community transmission has stopped. Screening prior to admission, we were using CT scans to screen. Now, fortunately, we can actually use PCR testing. So a little bit about the testing here. We are using the RT-PCR by KingMed Labs, and I'm not able to get sensitivity and specificity for this product for you. We don't have that yet. We are testing the public on demand. When our staff travels within China, we can't leave the country, but when we travel within China, we are tested upon return. We test patients prior to admission, so women in pregnant women, we test at 39 weeks and test their family members. So anyone who will be accompanying them into the hospital. Results are available the next day. Emergent admissions, we test at admission. Now, of course, we could test somebody at admission. They're already admitted. The next day we find a positive test. We do cohort patients, we do maintain patient isolation until a negative test. They are in a negative pressure room. Fortunately, our prevalence is quite low. Here's one note about the sensitivity and specificity of multiple PCR tests actually being relatively similar, except for one brand from France, and that included a brand being used by the China CDC. So while I don't have specifics for this RT-PCR, they looked broadly similar. And per this review in May, estimated lower range of sensitivity and specificity may be 70% sensitive, 95% specific. We still don't know what the gold standard is, so it's hard to tell you what the sensitivity and specificity might be. This other paper here showed a point of care test looking at saliva, actually, which was then validated with the RT-PCR, that fortunately showed the saliva really comparable to the nasal pharyngeal swab. So we are doing oral pharyngeal saliva sampling, and we believe that that is going to be as accurate, as sensitive as the nasopharyngeal, and it is an easier process to collect. So this is what that looks like. Our testing is done outside in a special booth. So we are protected by the screen, we have double PPE, and since it's really hot in Shanghai in the summer, we have the air conditioning. So our PPE is all as mandated by the Centers for Disease Control here. Now, it still can be kind of warm under double PPE, so we do have some vests with ice packs, which are really nice. There's a lot we don't know about the natural history of coronavirus still. The total documented cases in China at a little bit over 80,000 are less than you might see now in 2 days in the US. So the numbers that we just don't have the number of cases to pick up rare events. I've talked to a lot of my colleagues here, and we're not seeing a distinct post-coronavirus syndrome, nothing specific. Now, we've heard about effects on the lungs, and of course, if you're critically ill, healing from multiple organ dysfunction, but nothing that seems to be specific to coronavirus yet, 6 months out. But we would have a difficult time picking it up here. The concept of long-term continuity primary care is quite new. So with a more fragmented system without the continuity, we just may not be in a position to see those patterns. The Kawasaki-like disease, we did not see here. I spoke with the chief of infectious disease at Fudan University Pediatric Hospital, and it just was not noted. Again, that may be numbers. Between January 16th and February 8th, there were only a few thousand pediatric patients in total. Of that group, 126 with severe to critical illness. There were frankly only a few children intubated. It was winter season. You see less of the Kawasaki syndrome or the new inflammatory syndrome, we presume maybe less in the winter season. I did read that there was less frequency in East Asians. I don't have the attribution on that for you. And then again, we don't have the coordinated follow-up where we would pick up much more rare events. A study in the UK showed that the inflammatory syndrome may be coming several weeks after the initial illness. So that would be harder to connect to the coronavirus trigger. Second infections. This is where we all want to know, are you going to be immune for how long? What do antibody levels mean? What's the time course? And we don't have that data here, in that the first wave is gone, and the second wave, while we may have sporadic outbreaks, is not here. So we don't have people, frankly, exposed to a second infection. So this is a look at what it takes to guarantee that you won't contract coronavirus when working in a COVID ward. I'm going to go through this fairly fast, but this is here for your further reference. So this was a study of 420 healthcare professionals who left their work in other parts of China that were without any known coronavirus and traveled to Wuhan very early in the outbreak. Through April, they stayed 6 to 8 weeks and were all exposed to aerosol generating procedures in the ICU at some point during their stay there. Extensive protocol on preventing infection. This group was equipped with adequate PPE. We did read about a lot of physicians and nurses who were infected in Wuhan. Many were very early in the epidemic or were in places where they did not have this protocol. But I want to reassure you that it is possible to care for patients with known coronavirus in the ICU, doing aerosol generating procedures, and remain well. Extensive off-duty precautions for this group as well. So they remained isolated and were wearing masks 100% of the time when off duty, except obviously when eating, at which point they were in their room alone. The good news, 420 tested negative. So they returned to wherever they came from before Wuhan. They had a strict 14-day quarantine. They had negative tests at day 1, 7, and 14, and their serology was all negative. Now, this presumably was that earlier variant of the coronavirus, not the later one? We don't know. Is the later variant going to be more infectious than this earlier one? A lot of questions. But this is a protocol that would protect against aerosolized spread as well. So there are a couple of really wonderful videos here narrated in English that show the entire procedure, the doffing procedure, 21 steps. There are 10 episodes of hand hygiene during the doffing procedure. And if you're doing this in pairs, you're looking at 20 minutes to fully safely remove your PPE. So it is a lot of work. So just a still from this video, there's the beginning. You've got your pairs in a buffer zone, and there is a real human under there at the end. So it's possible. It's possible to safely care for coronavirus patients. What we don't know is less than this also going to be adequate? And that data is going to come from elsewhere in the world at this point. So how do you go on? How do you practice now? And my heart goes out to you. It is an incredibly difficult time. It wasn't stress-free before the pandemic. So whatever little bit I can share with you, I hope it helps. I do want to say the impact is profound on physicians wherever you are, whether you're in a hot zone or not. This study is fascinating. It tracked interns at 12 Shanghai hospitals. This is a study that started in 2018. They took a cohort of interns and had them track their mood every day on a scale of 1 to 10 on a smartphone app. And what you see is a moving weekly mean. I think my cat's saying something. Sorry about that. So we have a daily moving weekly mean here. This cohort, 2018 to 2019, you can see here as they head into the dark night of the soul here in winter, a little dip in mood, and then the Lunar New Year. Here is a time of significant elevation in mood. It's the major holiday. Now, 2019, 2020, this is a new cohort of interns. And it just so happened that the study had started the year before, and you have this amazing data to compare. There's extensive surveys, but this moving weekly mean here in Shanghai as the outbreak is starting in January, right back here, December, late December, January. There's some news coming out about something happening in Wuhan. And by Lunar New Year, which it was, of course, the extent of the outbreak was fully realized. And what we didn't know in Shanghai at that time was, will it come here? Will we be like Wuhan? So with only 718 cases total in a city of 24 million, it was still a huge impact on all of our lives. We initially didn't know if we were at risk for infection. Later, knowing that the outbreak was contained, we know our risk for infection is quite a bit less, but we are now dealing with the financial impact and rebuilding our practices and new ways of practicing that are more cumbersome and more infection control, and the challenge of knowing that our colleagues elsewhere are in fact on the front lines. So we're feeling it, and whether you're in an outbreak area or not, it has an impact. So remember, you're not alone, and reach out to your colleagues. And I really want to thank Nina for putting together this webinar and the topics that you've covered so far. So use that, reach out, innovate, use your resources, collect data, vaccinate, be a resource for your community, plan and drill, wear a mask. I can't stress that enough, everybody. Now I'm home alone, so I don't have one on, but I wear a mask all day, every day, to the point where I was about to take a bite of something, having forgotten I had my mask on, and about had mayonnaise all over my mouth. all over my mask. It's that serious. And that's with no known community transmission. On the left here is our consult app, which I am playing around with one of our fellows. But yeah, we innovated. We brought out an app for patients to ask physician questions. We haven't fully gone to video with this yet, but we are working on new ways of delivering care, as are you. So some things that you may be able to do in your practice. Again, I get it. I know how stressful this is. But where you can you keep a registry of patients who have recovered? What will be the long-term effects? Will there be a unique pattern? We as family physicians will be in the best position to know what this looks like, the natural history. Vaccine hesitancy. Now is the time. Here's a link to some great motivational interviewing information here on the website, on the AAFP website. And where I could go with this with my patients, if I were to say on a scale of 1 to 10, 1 indicating there's just no chance you would ever get a vaccine, 10 means you're going to be the first in line for the trial. If they're anything but a 1, if they're 2, you could say, well, why aren't you a 1? Oh, well, you know, I am worried about the disease. Now you have them telling you why they might actually get vaccinated. You're developing that. Because if you go at somebody who's already resistant, you need this, and they're already resistant, now you got their limbic system all activated, and data isn't going to work. So motivational interviewing, wherever you can get that in to reach those people who are on the fence. Some people are not going to vaccinate. We know that. You'll want to eventually have some protocols in your practice in a post-vaccine world where we may handle those patients differently. We may see them differently in negative pressure rooms. And it's not going to feel great, but we also are going to have to keep safety first for other patients. Immunize every visit. With telemedicine, there's a lot of visits that we won't be immunizing. So when you have a patient physically in the office, can you immunize? And influenza vaccines have never been more important. Anything we can do to decrease the burden on hospitals this coming year. And then organize, talk with civic leaders, elected officials, business leaders. Here in Shanghai, there's about 100,000 expats. So I kind of think about it like a city about a little smaller than Eugene, Oregon, where I grew up. And in this community, then, we are, as physicians, really important members of this community. I have a WeChat group, that's a social media app here, with the school nurses, for example, where we can trade information and share. Last year, there was a measles outbreak. So I don't give patient-specific information, but where I could rapidly share infection control protocols with the schools, for example. So where can you be a resource for school nurses, for your public health colleagues, for other family physicians? Where can you connect with your colleagues in different organizations, different hospitals? How do you rapidly share information on best practices, innovation? And this is what it's going to take, because one-on-one, as I stressed last time in April, we can't do this in your own practice. You can absolutely work on infection prevention in your practice, and I've got a lot more information in my April 4th talk on what that looks like specifically. But we can't make the kind of changes that we need one-on-one. Plan and drill, walk through. You want to walk the path that a potentially infected patient might actually take in your practice. What door do they use? How do you isolate them? Who might be exposed? And thank you, Nina, for the list of the public health departments across the country, your local health department directory. Work with emergency preparedness teams where you can. Now, some places are in the middle of it and you can't do this right now. But if your community is not currently in crisis, can you walk through a drill? Can you envision what you'll do if you have a potentially highly infectious patient in your practice? How do you trace people? What do you do for your staff? What's the quarantine period? How do you keep everyone safe? And thinking through this every step now is really essential. Unfortunately, we're thinking about this in the U.S. right now, and there's some papers on planning for mass respiratory casualty. A lot of the initial work was done more focused on what on a bioweapon might look like, some planning for influenza, but still some important thoughts there. When you Google vaccine, your first 2 or 3 pages, there's a lot of anti-vaccine information there. Can you create content to balance that out? If every family physician and every pediatrician put information out there, just the volume itself would help correct some of those that misinformation. Educating patients. This is a video we made on the emotional and mental health aspects of dealing with the pandemic and living in quarantine. I've got one on hand hygiene for patients. Feel free to take a look and share. Post on your page. They're not proprietary. If they're helpful, go for it. So can we create that content for our patients that will balance out some of the misinformation that's out there? So in conclusion, I'm going to let Nina take that over. But it's never been a more challenging time, but we can get through it. And please reach out, and I'm happy to take questions by email as well once this is done. So I'll turn it over. Thank you.
Thank you so much. That was an excellent talk. I'm really happy you're back to speak to our members. And before we go into the questions in the feed, I want to remind our viewers as part of T2P to reflect on how you think this might change your practice or what you do on a daily basis. And you can also put that in the feed so we can learn from each other. So the first question is from Will Sawyer from Facebook. And he asks, have you tried full face shields for the public at a large number or just masks?
Okay. Do you want to take that? Or you want me to take that?
Oh, you can take it.
Okay, yeah. So I had a couple more slides on the masks and the data of the efficacy. So on the masks, we have, of course, the healthcare setting where you're using N95s for any higher risk contact. We're using surgical masks, every physician, every staff, every patient, every time, 100% surgical mask. The only time my patient takes off a surgical mask is if a well patient, I'm looking at their oropharynx, they may remove it, but I have my mask on, and I'm getting into the face shield. If I have an ill patient, anybody, any drip of rhinitis, then they're in the negative pressure room, face mask, and face shield. So in the healthcare setting, face shields for every patient who could possibly have respiratory symptoms or infectious symptoms. Out in the public, face shields are being used in many settings, but are not mandatory. I think if you were to see community spread, we would see return of face shields. Back in February, a lot of people voluntarily wore face shields on public transportation before we knew the extent.
Thank you. That's really helpful. And then Marie Ramus from Facebook asks, there is concern about the psychological effects of having children wear masks and universal checking of temperatures. Any thoughts?
Okay. Here where it's a norm, where everyone's wearing a mask, it's not stressful in that, okay, we all do it. I did see a great book on the pandemic for kids and activities around, what is this virus? Why are we doing this in a really child-friendly way? So there are resources out there for how do we explain this to our kids. The temperature checking, again, it's like things we do every day. It's like hand washing, where you can couch it in, this is how we protect our friends. You know, the mask is not for protecting you, it's for protecting everybody else. And where that's universally adopted, I've really not seen impact on children just from those steps. And in fact, you know, when people are able to be out safely, there's a lot of benefit to seeing your parents and your teachers and your trusted adults protect you like that.
And then Bill Ang from Facebook asks, in China, are SNF residents allowed visitors?
Oh, skilled nursing facility?
Yes.
Yeah, so there really is not that much. I mean, parents are cared for in the home. There really is not so much of long-term residential care here as in the U.S. So during the peak of the pandemic in Wuhan, yes, patients were cared for without visitors, which is tragic to have people passing away without family. But in our, say, it's called postpartum rehab. It's a custom here to be cared for a full month after delivery, which is amazing. Yes, they are allowed visitors, but they're tested.
And then we have a number of comments of people thanking the series and for you speaking, and which is appreciated. And then we have a number of comments about schools. And if there's anything else you could share, since there's quite a few comments about what's going on with schools, and
Right.
We haven't started opening as significantly as you have. Do you have any other insights that you might be able to share?
Right. So on the schools, one of the challenges is all of these measures are put in place here. Community transmission is done. I can't tell you from living here, will this prevent transmission? We do know there's asymptomatic transmission. I also see that the American Academy of Pediatricians, the AAFP, is recommending school opening where possible, given the tremendous psychological benefits of being in school and needing to get back to work. So can you be a resource for schools? Can you go into a school with an infection control hat on, look at the space, walk the walk, have children moving in a way that's going to prevent as much contact, staggering meal times. So you're going to have less people eating at once. That may mean spreading out the meal times. So there's a lot of reorganization that will need to take place. And our teachers and principals do not have a medical background. So can you physically look at the space? And that's what it takes to look at how do you enter, where do you wait, can you have that 1 meter social distancing? And it's an enormous challenge, and budgets are tight and tax revenue is down. So I don't have any magic for you, but wherever you can innovate and be 100% on board with mask wearing, all children, they can do it. Even little kids can do it. If this is what everybody does, it's what everybody does. And the kids will adapt. They really will. For specifics, I do have a whole list of things to think about. I have a whole presentation actually on preparing your schools for opening with a lot more specifics. So I'm happy to send that out. I put my email on the slide. I don't know if that's still there, Nina.
I think they can also contact you through the member exchange message board.
Great. Let me make sure to log in there. And can I post my school opening slides on the member exchange board? Yeah. So look for me on there, because I have I did a whole talk on preparing schools for opening. And whatever, don't let the perfect be the enemy of the good. Whatever you can do is going to be helpful.
And then following up that, Kai D from YouTube asks, in China, are infants wearing masks?
The youngest I'm seeing, yeah, later in the first year, the youngest infants are just not out in public. Here, maternity leave is minimum 4 months, and grandparents there's multi-generational families. So infants are cared for in the home. It's a lot more common to have a hired care provider. So there really is not hardly any group care for the youngest. But yeah, children I see in public, 9, 9, 10 months, over a year. Yeah. And it's, again, when it becomes a norm, they tolerate it well. Obviously, you wouldn't want to do that at night or when sleeping, but I've not seen any data showing harm for well children wearing a light mask.
And then to follow up that, Susan Hill from YouTube asks, any thoughts about how masking is going to affect children learning social cueing and empathy, important for 0 to 3, especially seeing smiling for brain development?
Right. Will we get to a point where children in group care are wearing masks, but as 3-year-olds, they're probably going to be taking them on and off a lot more than we like? That's a fantastic question. They will, of course, in home with the parents be without masks. You're going to have most of the day being with caregivers with normal facial expressions. Fantastic thought. And this won't be forever, but yeah, I think if you're able to get to where you have, say, a bubble of people who are within that bubble known to have tested negative, teachers who are only going to school and home, families who are only going to school and home, there may be more freedom to not mask. But that'll be dependent on a lot more variables.
And then for Delana Wardlow from Facebook, who's asking for your email address, we are going to post it, the information onto the member exchange message board that Dr. Jordan was speaking about. So we have one last question because we're nearing the end of our time. And Rochelle Parker from YouTube asks, is asymptomatic COVID infection less contagious than those with symptoms?
I'm not sure I think there's so much variation within each group that I don't think we can say asymptomatic carriers are not a risk, basically. We know it spreads through asymptomatic transmission. It's possible the newer strain is more transmissible than the older one. So I think we have to assume everybody's high risk until proven otherwise.
And then with that, I want to thank you, Dr. Jordan. Thank you for being our first speaker and our last speaker. It's been wonderful having you, and you've been a pleasure. And the information you've given us from China has been irreplaceable. And I want to also, since this is our last session for the COVID-19 webinar series, I want to thank everybody who's been involved with putting it together and thank our members who've been watching throughout the series. The people who've been involved in the background that you might not know about have worked effortlessly along with our speakers who've come on. People did not have to be on phone calls to China at 11 p.m. at night or fixing glitches at the last minute or even jumping on phone calls at 9 p.m. at night or Friday nights like everyone else who's been watching. So I just want to thank everyone. We're in it together. And
Yes.
if you have any comments of what you need, feel free to put in the message exchange board, and everybody's monitoring that, and AAFP has shown that they're ready to assist and try to give what you need on the ground. So I just want to remind everyone there is a talk in a month. Please join Dr. Gary Leroy for the next COVID-19 Town Hall on Wednesday, August 12th from 7 to 8 p.m. Central Standard Time. Thank you.
All right. Ciao, yo. Take care, everyone.